from this end is to bring the idea of context. Because, if you look at COVID over the last 1 year, there have been huge differences in the way it's played out in Africa versus Asia versus, different parts of the world. And so there are no one size fits all public health ideas, but context matters hugely. One of the special signatures that we've had in this program is we've always had a speaker from Africa. Just this time around, we couldn't handle more than 3 speakers, so I'm sort of our team is feeling a little bad that a special, unique distinction of having a speaker every time from Africa we don't have. So thank you again very much for joining us, and welcome all the participants. And Dr. Gupta, would you like to start? We've sent out all your CVs to the participants and everybody, so I won't, belabor the introductions about all of you.
The housekeeping message.
I think there might be one housekeeping message before you start.
Pavitra, can you give the housekeeping message, please?
Why don't you just tell them what the housekeeping message is?
Hi everyone, I'll just quickly go through the housekeeping instructions. For anyone who's not familiar with Zoom, so as an attendee, here are your options for the, for Zoom. So please check your audio settings. That's in the top bottom right corner, left corner, sorry. This will open this up for you. You can raise your hand if you want to ask a question live, but it depends on the time and our moderators. The Q&A box is where you will have most of your time spent, where you can put in all of your questions and our moderators will check those and choose which ones are most pertinent. So you can also ask your questions anonymously, so please do that if you wish to. And that's it from my side for the housekeeping instructions. Back to you.
So Dr. Sunetra Gupta, would you like to start?
Yes, sure. Okay, I'll just, how do I share screen? Okay. Thank you so much for asking me to participate. It's a real honor. I'm just going to talk very quickly because I think that is what we're the ostensible, kind of micro topic at the moment, although it's very difficult now to focus in this current situation to focus on a particular aspect of this whole crisis. But nonetheless, I'll try in as quickly, as briefly as possible to discuss one of the central issues that, of course, defines how we respond right now, which is whether we can recruit herd immunity in any way, or can we rely upon it to help us control this pandemic. So this concept of herd immunity, which has been much reviled for reasons that are not entirely clear to me, except that herd somehow has connotations of some sort of management of animals, which, at one level you think, well, that's true, that is where this concept derives from, is in recognizing that our relationship with the virus is an ecological one in which we are the herd, we are the hosts to this pathogen. And the way that we understand the details of this ecological relationship is often through mathematical models, of which the kind of standard SIR model that's been used pretty much universally to look at the spread of this disease is kind of the simplest example. And that's why I'm showing the little toy car here on the side. It's something I often pull out to explain to people why models have to be simple. It's because they're essentially abstractions of the reality. But the notion of herd immunity essentially arises from models which typically were developed for diseases that gave you lifelong immunity, such as measles. And the idea was that you could understand how measles might spread through a totally susceptible population by writing down a set of equations which reflected the dynamics within a model, a compartmental model in which people are either susceptible, infected, or recovered. And of course, recovered here implies that you have immunity to further infection, at least for the time being. And within the timescale of this epidemic, if you assume that immunity lasts at least for that duration, so in other words, is not lost immediately, you get this sort of typical kind of dynamic whereby infections arise in a population, the susceptible compartment is diminished, and people start ending up in the recovered compartment, which slows down the growth rate of infections and thereby it turns over. So there's a sort of self-limiting density dependence inbuilt within this system that limits the growth of the epidemic and eventually causes it to settle to some kind of endemic equilibrium. Now, this is just a snapshot of what would happen in the first wave. Typically, what happens is you get subsequent smaller waves, and then you settle into this state of endemic equilibrium where you have a level of individuals in the population who are, the proportion that's immune is maintained at a particular level that is dictated by the fundamental transmission potential of the pathogen, which is something that you can also derive from the equations that you'd write to describe the system. But essentially it describes how good the pathogen is at getting from one person to another. And so it's sort of a fundamental measure of its potential. That's what determines the level at which population immunity is maintained within these systems. And what you have typically are just fluctuations around that. So you get sort of seasonal peaks, or sometimes you might get extra seasonal, extra annual behavior, but it's all essentially kind of wobbling around that equilibrium state that is reached. And at that equilibrium state, crucially, the risk of infection is not zero, it's non-zero, but it's as small as you might expect, as you could possibly expect to keep it through the mechanisms of natural immunity alone. Now, you can make much bigger, more complicated models. This is actually a model the Imperial College Group used to model the spread of flu some years ago. And yes, this is a more complicated model, hence this rather more elaborate toy car, but it effectively does the same thing. It shows in green, again, the buildup of immunity to a particular strain, in this case, flu, shows how the infections will rise and pass in a matter, in this case, of weeks. So as you can see here, between week 1, by week 13, you're clear, you're back, you're in a state where a large proportion of the population is immune for the time being, and by week 15, the infection is gone. So that's the typical behavior of these things. So where are we? Is this what's happening with SARS-CoV-2? Well, there is every indication that despite, or where lockdown has been possible, and I've said a million times over and I'll say it again, lockdown is a luxury that is obviously something that can be considered by affluent countries, by affluent households, and particularly, of course, by small affluent countries, that are located in small islands. But so obviously it has, of course, nonetheless been implemented and then withdrawn, and we're about to go into lockdown again in the UK. But within those constraints, you can still see, this is a graph showing in the UK how the epidemic has spread in different locations. And you can see that pre-lockdown, if you like, there was a typical kind of epidemic curve whereby we went from low infection. So the red here shows the peak of the epidemic, if you like. So you get to a peak and then it starts to come down. Now, some of that coming down was in the UK naturally aided by lockdown. But overall, you see that pattern going from London up northwards. And then what happens is, of course, it didn't reach some of the northern regions, which is why now you're seeing an epidemic peak in those regions. So that's all consistent with the sort of idea that immunity builds up. This is also a similar pattern in the US, in the different states. And one of the great problems I see sometimes, or a way that people have used to manipulate data, is by lumping it all together. So, you know, you can start to say, oh my God, there's a crisis where all cases are going up on a countrywide level. And of course, what that disguises is the actual SIR dynamics that's occurring at regional levels. And this is just some data from Brazil in Manaus, where again, you see these typical patterns of rises in infections and then a fall due to the accrual of herd immunity. How do we measure? How do we know where we are at in this process? Is herd immunity accumulating? Did lockdown come in early enough in some places that it didn't accumulate? It's very difficult, obviously, to distinguish between what brought cases down in areas that have gone into lockdown. So a long time ago, well, in March, when we put out our first sort of theoretical exercises, we stressed that what we needed to do is determine exactly that. And so Craig Thompson in our research group went ahead and developed an antibody test, which, and then Rob Payton, these two people in our research group, did a very thorough analysis of some samples that we got from Scotland. And we found the antibody levels to be quite low. And this has been also the case, well, the data I showed you in Manaus they had very high antibody levels. And as many of you know, there are pockets in India as well, and many parts of the world where you do get these very high levels of antibody in certain locations. But there are also areas where it appears to be going away, where the antibody levels are quite low. What does that mean? Well, all it really reflects is that antibodies disappear very quickly from the blood in the case of this infection. So antibody levels are not a good way of assaying how much immunity has built up in the population, just because that immunity will be stored in the B cell memory, but it isn't manifest in the humoral, response in the blood. Furthermore, we have antibodies at a mucosal level that can protect us, not to mention a whole arsenal of T cell responses and other innate responses that can protect us. So it's very difficult, it turns out, so much against what I'd hoped, because in influenza, you can use antibody levels to at least survey the level of exposure. But here, because the antibodies decay so quickly, we don't have a means of doing that. So, but nonetheless, the question is, okay, so let's say there are immune responses. The other issue, actually, before I go on to that, is that we also have immunity, it appears as most likely to be, from pre-existing responses through exposure to other coronavirus, seasonal coronaviruses. And we've, Jose Lorenzo and our team has modeled how that affects the level of immunity that you need to acquire further in order to suppress or bring down levels of infection. And that varies, not surprisingly, crucially, it is dependent on what proportion of the population is already immune through exposure to previous coronaviruses. And I've been trying to introduce, for two reasons. First of all, to get that point across, but also to address the very crucial question of how long does this immunity last? So let's say you get immunity. So far, the signature in all the data is that there is immunity and it is impacting levels of infection. But how long will it last? Well, if you look at these other coronaviruses, the seasonal coronaviruses, they do not confer lifelong immunity like measles, but they do give you immunity against reinfection for about, 4 or 5 years. Unfortunately, we don't have many studies, but so the pattern there is different to measles. The pattern is one where you get immunity, then you get reinfected every 4 or 5 years, which likely tops up that immunity, possibly focuses it on specific corona strains. but reinfection does not carry with it a cost of disease. So what I've been trying to impress upon people who keep wheeling out these arguments that there is no immunity to coronavirus, which is nonsensical, and several studies attest to the fact that there is, but that immunity also is likely to decay. I think we can go by what we know about other coronaviruses to try and come up with a sensible baseline idea about how this might behave. And essentially what you have is, for any infectious disease, no matter how quickly immunity drains away, is kind of a stable level, which is dictated, as I said, by the basic reproduction number. So if you think of it as a sort of cistern, you have a tank here where the level is going to remain the same, dictated by R naught, but it leaks. And the leakiness is determined by the rate of loss of immunity. For measles, it leaks very slowly. Only when people die do you lose immunity in the population. Something like coronavirus is leaking quickly, much more quickly, but it's also being replenished very quickly. So overall, you still will maintain the same level of immune people in the population, and the risk will be lowered to everybody in the population by virtue of the maintenance of that level of immunity. Now, then you might say, well, what about the reinfections? Well, as I've just said, reinfections typically do not just in coronaviruses, in many other diseases, don't carry a huge risk of disease and death. So what we have here is a dynamical system in which the levels will be maintained at pretty much the same level as any other disease with similar R naught, but you will get a flow in and out, but that flow is not a dangerous phenomenon. So just to end with one other point, which, as I said, you cannot think of the dynamics of or how to deal with COVID just on the single axis of what's happening with the virus, how much immunity is building. So I've been using generally, to get that point across, this kind of Aristotelian rhetorical triangle, where I say that we cannot think just on the basis of logos, which is essentially what I've just been describing, which are the mechanics of the system. We have to take into account the pathos, meaning the socioeconomic costs of any measures that we bring in to try and contain the virus, not to mention ethos, which has to do with how we want to live our lives in the first place. And I mean, I could obviously go on forever. In fact, we're setting up a website to document the collateral damage done by lockdowns globally. But you will be familiar with the fact that the costs of lockdown are enormous and profound, not just at a local, regional level, as I'm trying to convince people in the UK, but globally. So we need to find a different way out of this situation. And that is afforded to a degree, by the age dependence in vulnerability to death and disease, which, first of all, and I'm not going to go into any detail here, once you use a model, take a simple model and include this sort of separate section for vulnerables, you realize that some of the dynamics that we're seeing needs to be interpreted at a slightly different level. But most importantly, what that vulnerable age dependence and vulnerability to some explains or affects is the actual mortality, the death rate, and the years lost to death from coronavirus or debility, and why that's so different in different parts of the world. So just to finish, I'll have to perforce push what I consider to be a workable solution, which I think, basically it's predicated on the notion that lockdown is a luxury. It's not even a luxury that countries like the UK can afford. And this needs to be the baseline. This is the position from which we're coming. So what do we do then? So one solution that's afforded by this age dependence and vulnerability is that perhaps we can use such resources as we have to shelter the vulnerable. I mean, this itself is also a luxury. Sheltering the vulnerable is not something that can happen everywhere, but to the extent that we could shelter the vulnerable and allow immunity to accumulate, to take us to that place where we have the lowest possible risk to those who are vulnerable so that they may resume, or we can go back to normality. Obviously, this does include investment in therapy and vaccination. They're not at odds. And this is the fourth slide, of course, is something that you've already stressed, I think, in your introduction, that we absolutely need to think outside national boundaries. And I think it's shocking that the response of so many countries, typically those who are affluent and able to close their borders and somehow stagger through lockdowns, that they have put that forward as a reasonable international response to this virus. So thank you very much again, and I will stop sharing my screen and we can move on.
Do you want to take a quick question?
We'll take the question at the end.
Can you just tell her? You want to take a question now or later?
We'll take the questions at the end. We have just one question. I think all the other speakers will also have something to say about that. So we will move on to our next speaker.
Okay, Dr. Jan Albers, thank you. Would you like to start? We'll take the questions at the end together.
Yeah,
Yes.
Thank you. I'll share my screen then, and thank you, Dr. Gupta. So you see my screen now, right?
Yes, we
Someone
should.
is nodding. Yes, thank you. So I'll give you my view, which is partly personal in a sense on the COVID and SARS coronavirus 2 situation and future, both in Sweden and elsewhere. Many of the things that Dr. Gupta spoke about, I agree on. Maybe will have a few qualifications here and there. I'll start just briefly by mentioning who I am. So I'm Jan Albert, as you see here. I'm a professor of infectious disease control, which is really translational virology. And that's at the Karolinska Institute, which is the medical university. I have one or two slides on sort of the Karolinska Institute. And then I'm also a senior consultant in clinical microbiology at the Karolinska University Hospital. And my office, which you see here in the back, is actually at the hospital. So I have my workplace at the hospital, which is run by the region of Stockholm, whereas the Karolinska Institute is and all the universities in Sweden are run by government. So the Karolinska Institute is a medical university, largest in Sweden and ranked quite high internationally. It has two sites in Stockholm. It was started in 1810. I just walk through this very quickly now. And has of course developed since 1810. Two locations. Here is the center part of Stockholm. The one campus is in the north, just north of the inner city, and one is a little further south. There are around 6,000 full-time students, medical students and others, doctoral students, 300 professors, and it's a large university, but only a medical university. So it's not like Oxford, which has a lot of other activities apart from medicine. Then the Karolinska University Hospital, which is a different entity. So I have two employers. It's a large hospital, one of the larger in Stockholm, but there are three other large hospitals. And the Karolinska University Hospital has two sites, 1,600 beds or more. And you can see some other facts here. And there's a tight link, of course, between the hospital and the Karolinska Institute, but they are two different entities. And I work then at the Karolinska University Laboratory, which has 2,000 and more employees. One of the sections is microbiology. Microbiology has 300 employees. We process around 2 million microbial analysis a year. And now, probably with COVID, we will do another million or so just in this year. Well, here are some other facts about the clinical microbiology. So this was a very brief introduction to who I am and where I work. And I maybe didn't say, but it's Stockholm, which is the capital of Sweden, which is a relatively small country in the north of Europe. So, so the global situation. This is now some of the names of countries here are in Swedish, but I think you recognize them. So we have Sweden, here we have India, we have the UK here, partly covered by the US. And you can see that in Sweden, we had an early rise in cases. This is number of deceased per 1 million inhabitants. So we had an early rise in the fatalities, big strain on healthcare and ICU, but it didn't collapse. And then it leveled off during the summer, and we are just now seeing a slight increase, but not a dramatic increase like, for instance, Belgium, Italy, and the UK. Part of what I will discuss is whether we are just a little later. India, of course, is down here, but I think that these comparisons are difficult because reporting differs so much. I mean, there's been a lot of international discussion and also criticism of what's called the Swedish strategy, which sometimes has been portrayed as doing nothing and just letting people get the infection and then have herd immunity, which is very far from true. But there are some differences with the Swedish strategy, and that's very well outlined in this paper that was published relatively recently by another Karolinska Institute professor in Acta Pediatrica. So Sweden has had more of recommendations on social distancing than strict lockdown. But if you look at sort of social interactions, travel, things like that, there have been significant reductions in many aspects of normal living in Sweden as well. But it's not law enforced. We have had no police on the streets. One big difference is that schools were, at least the younger children, they were allowed to go to school all through also the spring, and they still are. I think part of the reason why Sweden has had this slightly different strategy is that we have a public health agency, and we have a tradition that government agencies are free and are acting without very strong interaction by the government and the politicians. So the Public Health Agency of Sweden has pretty much designed the strategy, and it's been based on science more than sort of politicians wanting to look strong and powerful and decisive. And the strategy was from the very start. We had a slow start, and we had a probably unnoticed influx of infections. So when we realized that we had a problem, we already had quite massive transmission, which is similar to many other severely hit countries in Europe, like the UK, Belgium, Spain, Italy, and so on. But we didn't have a strict lockdown. The strategy was designed to be able to sustain over a long time. There have been sort of minor changes through the pandemic so far, and we will have still other minor changes, but most of it is the same since the spring, early spring, I would say. So Sweden then, so these are plots and figures from the Public Health Agency pulled out the day before yesterday or yesterday. So these are cases. This is through the entire pandemic. This is just the last month. Here we have new ICU admittances. And here we have, sorry, this is a mistake, should be deaths. I copied and I forgot to change. So these are deaths. So you can see that we had slow increase in diagnosed cases, mostly because we had limitations in testing, like basically every other country. When testing started to become more available, we had an increase in diagnosed cases, which was not really an indication of more transmission, but rather transmission were on the downslope, shown by both new ICU cases and deaths. So summer was very quiet, hardly any deaths or ICU intakes, but still some diagnosis. And then starting like in September and increasing now, we see increases in the number of diagnosed cases. So the proportion of positive tests, for instance, in my lab, has gone from 1% in the summer to 10% or more right now. But we are still not seeing a huge increase in the number of newly admitted ICU cases. So you can see that we're still in entire Sweden, population of 10 million, we're at less than 10 a day. And we had many, many more in the spring. You can see that here, we were topped at 40, 50 per day. And also the deaths are still low, less than a couple of a day. But of course, there is a fear that this increase will translate into increases in these numbers as well. And that's what I will discuss a little. What can we expect based on data and speculation? So very similar to Dr. Gupta, I will talk a little on seroprevalence, T cells, herd immunity. So I will try to discuss how many may have had the infection in Sweden, or I will mostly talk about Stockholm, which is the capital with 2 million inhabitants, like 1/5 of Sweden. Will everyone develop antibodies? Is everyone susceptible? And how many need to have antibodies to see an effect of herd immunity? So let's get on with some of these questions. So seroprevalence then in Sweden, the Public Health Agency has done community sampling. The last report was from early summer, but then, and you could say then that maybe this is too old, but we didn't have many cases in the summer. So up until September or something, at least this is probably is quite valid. And you can see that, so these are different age groups. This is now entire Sweden. 0 to 19 age, 22, 64, and then persons above 65. You can see that the bulk of the persons who have antibodies are among younger adults and adults. And the overall in Sweden in the beginning of the summer was like 10% or so in the group that has had the highest levels of antibodies. But looking at different regions of Sweden, Stockholm was more severely hit than the second largest city, Gothenburg and neighboring area, or this third largest city, Malmö. And so in Stockholm, the seroprevalence at the beginning of the summer was above 10%. And then, of course, we've run at the clinical lab here, we've run more than 500,000 serological tests. And of those, 15.7 have been positive. This is now through the entire pandemic. If we look at more recent time and in younger persons, the same age group here, 20 to 64, it's above 25%. So the question is, so say that this is a true figure, which is of course difficult to know because this is not random testing, it's persons who have opted to be tested. So, but even if it's a true figure with 25% or so in the age groups that have the highest antibody levels or seroprevalence, you could say that maybe 75% are still susceptible. And I will discuss what we know and don't know about this. So, will everyone develop antibodies? Well, there have been indications that maybe is not the case, but then there are some reports, especially this one from Iceland, which is almost like a community sample, looking at many cases, many of those have been mild. And of 1,200 confirmed cases on Iceland, 1,100, like more than 90% developed antibodies. So I think that the concept of a large proportion not developing antibodies might not be true. There are many other reports, also from Sweden, but not yet published, that sort of show the same thing. And then we have this very interesting thing about T cells. This is a Swedish paper in Cell with a large group of authors, but there have been others with similar results. One can say that it's very clear that persons sampled even before the pandemic have T cell responses, mostly helper T cells. But whether they are protective or whether they modulate the disease is still really an open question, I would say. There are indications pointing towards that they might provide some protection, but there are also indications that they may more be like something that might modulate the rate of or the risk of severe infection if you become infected. Time will tell. And then the question about, is everyone susceptible? There was a recent report from a fishing ship, I think it was in Japan or Korea, where almost everyone got infected. Was a group of, or say the number of crewmen on the ship was over 100, and 80% or so got the infection when they were out for a couple of weeks. But we have this interesting indication that children, the attack rate for infection in children is lower. And there are many indications of this. One is, for instance, that the seroprevalence in children, for instance, in this Swiss study, is significantly lower among small children. And of course, I originally thought that these sort of things were due to less severe disease and not getting tested. But this study and also this study indicates that they actually may not get infected to the same extent. This is the same Icelandic population, but a different analysis where this is our PCR results, and the children are much less likely to be PCR positive if they are tested. And this is almost like a population test. So why may children be less susceptible? Well, I mean, for other respiratory infections, they are like sieves. They get it all the time, and then they spread it to their parents and other children. But maybe they are in some way protected, and that could be these T cells, could be more active innate immunity. So it's not really like a true memory, but more like more active innate immunity, less exposed, probably not. And if children to some extent are, small children to some extent are protected, what about adults? Are there some adults that are also in some way protected? We don't know. There are indications saying sort of go in both directions, I would say. We don't know. But important for herd immunity and the herd immunity concept is whether everyone is susceptible or not, and we don't know. So, well, herd immunity, as Dr. Gupta already explained, is simple predictions suggest that with an R naught of around 2.5, which has been reported for SARS coronavirus 2, 60% seroprevalence or so is needed for full herd immunity. But there are also a more sophisticated analysis, and one is from Professor Tom Britton. He's based in Stockholm, published in Science, I believe, that because the spread of the virus is not uniform through a population, the herd immunity threshold will diminish when the pandemic progresses, because the more susceptible, the more high-risk persons, both for becoming infected and transmitting, will be first infected and become immune. And that's very much it's another sort of aspect of what Dr. Gupta talked about when it comes to, you can't look at an entire country or even an entire city if it's a large city. You have to look at smaller units. And so he modeled that 43% maybe is sufficient, but if some are not susceptible, maybe this figure is even lower. But again, we don't know. So we heard a little about the seasonal coronas, and we've been looking at that in my lab based on the routine testing that we do in the clinical lab. So we've looked at 50,000 tests over the last 10 years. And what we see is we have very sharp peaks in the wintertime for these coronaviruses. And this is the different colors are the 4 different species. And we, so what we have seen and also reported already in February is that we can expect seasonality of SARS coronavirus 2 as well, and maybe part of the sort of peace we had during the summer in Sweden and many other countries in at least in Northern Europe was due to seasonality, and that this effect is quite strong, which is of course bad news because we're still in early fall. So can we expect a second wave, or are we experiencing a second wave? I would say we are in parts of Europe. So my impression or my view on this is that the risk for transmission will probably continue to increase when we go into winter, at least in countries like Sweden. We are still not clear really about how many have had the infection because, as Dr. Gupta said, antibodies do not last forever. And another thing about the seasonal coronas, we definitely see reinfections. So we can't expect lifelong immunity from SARS coronavirus 2. How long? A couple of months, couple of years, probably, and it will differ between different individuals. How many are still susceptible in Sweden or in Stockholm? We don't really know. And sort of to counteract this increase of transmission that we see now, both in Sweden and elsewhere, I think that social distancing, but not full lockdown, is required, because otherwise we risk having too much cases to cope with in healthcare or in the hospitals. And sort of coming back to the Swedish strategy, or any strategy, it's too early to evaluate which strategy or which part of which strategy is more successful or less successful, because we've just seen the start of this pandemic. It will continue. And the virus will become endemic. It will be fifth seasonal coronavirus. So that was it. And I don't know if I ran over time. If so, I apologize. So I'll stop sharing now.
Should I go ahead? No, that's fine. We're good on time. Dr. Jayaprakash, would you like to go ahead, and you could sort of lead into the discussion with Partha after that. So go ahead.
Okay. They had two excellent presentations, and I will be brief. When I started my career in Vellore, South India, I was a doctor who worked in a small secondary care center with an outreach program covering a population of more than 100,000. And my work included not only sitting in the hospital, but also reaching out to villages, seeing how things happen. And I remember those days, measles used to come regularly. I use the word regularly. In fact, it was so every 3 years, we used to have an epidemic of measles. And it was quite impressive how this whole community faced the music and bore it through. And measles in rural India was a very serious disease. And many children died then. But this three-year gap was interesting for me as a young doctor. And the logic they told me was, you have to have susceptible to build up before you can have another epidemic. Then I found in the case of German measles, it is even longer, 7 years. And actually, I didn't realize at that time, I was staring in the face of herd immunity. Now, later, of course, I underwent the proper training programs in epidemiology and learned about these things. But when this whole thing came around in the corona epidemic, there were certain very, very confusing remarks. And one of the first one was that it does not produce any adaptive immunity. How does anyone know that? Because it's the very early days, but people seem to be sure. That was very, very upsetting. You know, this kind of a controversy is in medicine very often. And one of the celebrated controversies is between Bradford Hill and R.A. Fisher about the smoking and whether it is causally related to lung cancer. But Bradford Hill, of course, went on to formulate certain constructs which we use in studying causality or basically understanding truth. And he inserted two important words in that list he created, plausibility. And the second one was coherence of evidence. Does it make sense? Now, we have only one biology in this world. All follow the same rules. The virus could get into our cell only if it carried a protein-made key. The problem with the protein we made key from the viral point of view is that body recognizes it and responds. But the message was coronavirus of this COVID-2 did not stimulate an adaptive response. But then you could see people are clearing the virus. Wow, that was quite amazing. Anyway, what I want to try to tell you is that there was this misconceptions about the whole thing. And I happened to talk about herd immunity, and by the time it had become a bad word in science. So it was quite embarrassing for a little while. Remember, what was I going by? I was going by the rule of nature. Viral infection produce usually a good immune response. There are very rare exceptions and there are reasons for it. But by and large, we see good response. And why shouldn't we expect good response here? Other coronaviruses, some of which we live with, also produce responses, which makes us secure against them. So this was not fitting, or it was not coherent with the knowledge of the biology we had. So, and that time, I want to tell you, this is an interesting thing. Florian McMahon, he came out with a beautiful little paper, and the message was, COVID-19 infection stimulates a robust neutralizing antibody response, which lasts for at least 3 months. Now, this report I didn't see. I had saw first an edited report which rubbed off robust and rubbed off last for at least is taken off. So it read, coronavirus infection produces neutralizing antibodies which last for 3 months. Now, in India, we have a habit of using the word only in all our sentences, okay? How was Dr. JP's talk? Nice only. I mean, we had only for every sentence. So subsequently, this particular line got transformed into COVID infection produces neutralizing antibodies for 3 months only. And that is the prevalent knowledge in India. Everybody's sure after 3 months, you got to get the disease again. It's very unfair. In fact, we find in our context, the antibody response has been quite large, unlike any European country. For the simple reason, the whole concept of protecting oneself is almost impossible for our people. They have to go work every day. And so naturally, ours are some of the highest antibody levels anywhere seen. Now, I agree that this exposure comes with a cost. A lot of people have to die. On the other hand, we have no alternative on it. People cannot be locked up. The society is poor and they need to work to earn. So in this context, what has happened is most large urban areas who got hit by this virus early, and the immune response was climbing. In fact, the big slums in Mumbai, Chennai, Bangalore, all of them have shown 40 plus, 50 plus responses. And now we see the epidemic in general in many of these areas. I'm not taking the whole city, is coming down. And even cities like Chennai is coming down. All India, there is a fall. I'm not saying this is going to go away, but the response, the only reason the new cases are coming down is because the proportion immune has been climbing. And to make a long story short, we have a long way to go. But I think our whole process of dealing with the coronavirus has disempowered people, frightened them, created stigma. And finally, even those who have had COVID and had good antibody response are scared, will I get it again? This is not fair. In my opinion, I would like to emphasize every time I climb up anywhere, listen, you had COVID? Yes, you are clean. You are very, very, very unlikely you will ever suffer from COVID disease anymore. So I would stop now because our time is short. Thank you for the patient listening.
Partha, over to you. You can go ahead and structure the discussion any way you want to.
Sure. So first of all, let me thank Professors Gupta, Dr. Albert, and Dr. JP Muliyil. So it's really nice that we heard 3 points of view. There was convergence of the points of view that there is growth of immunity, and herd immunity is something that is happening in most countries of the world, although we also heard a little bit of discordance. I want to bring this, take up the first bullet point, or sort of last slide, first bullet point of Professor Gupta, which is shelter the vulnerable. Although she said that, sheltering the vulnerable may not be possible in many parts of the world. In India, for example, one of the things that she has proposed is that let the non-vulnerables go to work, let them lead a normal life and shelter the vulnerable. But in countries like India, where there is, the amount of accommodation, the square feet of accommodation that we have inside of the homes is so small, if the younger people go out to work and they catch the infection and come into the household, how would anybody be able to protect the vulnerable? So that's one major question that has arisen here in India for those of us who believe in herd immunity, and that's a real problem. The second problem is with respect to, when there is herd immunity, there will be a large number of cases. Many of them will probably be asymptomatic, but still the number of cases, are we prepared to handle the number of cases in terms of hospitalizations and other kinds of care? So this is really a question to all of us, all of the three speakers, and I would like Professor Gupta to react first.
Sorry, yes, of course, that is the critical question. And that is why I said that itself is also a luxury. So what we're faced with, and, as so beautifully put by Dr. Muliyil, is that, what are our options? Do we, can we lock down at all? And I think the point is that in most countries, it's just not even an option. So in that situation, what do we do? Well, there are some countries that can at least afford to shield their vulnerable. So that's really the position that one is putting forward at a global level. But of course, in order to get people to listen to it and think of it as being acceptable, that has to operate in a local situation. So the UK has to decide, for example, and they have, that whether they go into lockdown or whether they can shelter the vulnerable. And they've decided to go into lockdown. So it's true. It's a decision that can only be enacted given a certain level of resource. That said, I do think there are measures and practices that could be adopted to reduce the risk to the vulnerables. I mean, as Dr. Albert said, no one is advocating, even those of us who think herd immunity may play an important role, no one is advocating that no measures are taken at all to try and contain the spread of the virus. In other words, to sort of spread it out to a point where health systems don't become overwhelmed, and also to do what we can to protect those who are situated, vulnerable people who are situated within homes for whom there is no alternative. Finally, a note of even more optimism is I think that there are reasons to believe, and they need to be explored, that elderly people in settings where they have more exposure to young people actually enjoy a level of protection against some of these diseases. So again, the landscape here is, as everyone pointed out today, the other coronaviruses and what protection they give to us, and because this is a disease unlike measles, where you don't get lifelong immunity, you have to keep getting reinfected and topping up your infection levels. I think that's something we need to consider. I've mentioned in other talks a study that came out of Scotland showing that people, healthcare workers who had children, were far less likely to, and this scaled the number of children, to go into hospital with COVID illness than people who weren't exposed to children. Anecdotally, we know that many people become ill but with flu and other respiratory viruses once they have grandchildren, because they enjoy, for a while, they have a period where they don't actually see young people much in this country. So maybe there, just to turn it on its head, maybe there are lessons to be learned in countries where the elderly are shielded or not exposed as much to the other generations. And maybe the UK and other places would do well to set up places for that to happen more. So having children from nurseries visit care homes and whatnot. I think we need to really revise the way we think about all this in the future.
JP, you have been one of the first people in India who advocated for herd immunity, but there are these kinds of constraints. Do you have any thoughts on those? How to overcome those constraints?
Yes. Now, way you have to think about is the mortality differential is huge compared to young and the old. And since you can't do much, it doesn't mean that you lock down everybody. I mean, that's not a solution, because, and it is not a workable solution in India, because people have to somehow earn a living and eat. And so what are you offering them? Starvation death or corona death? I mean, that doesn't make any sense to them. Number two is that many of the people, especially in slum area, it is impossible to make sure that there is isolation from one another. I mean, they are all living in one big mass. On the other hand, people who live in better housing, they can afford to isolate themselves. So in other words, there is no solution for the whole country, but for certain groups, there is a solution. Even wearing a mask and keeping a distance can reduce the risk of transmission within household. And we have data to show that this is lower if you take care of it. So I'm not saying that what the solution, when you can't protect the elderly at all, then what you do is you lock down everybody. That is not a workable solution at all. That option doesn't exist. And that is my problem.
Dr. Alberts, when we were chatting before the other speakers came on, you essentially said that mask is not even promoted in Sweden. And you felt that there are studies or at least you felt that there are no strong studies that show that wearing a mask actually is protective. In view of what
sorry, I want to qualify that. It depends a lot on the situation, but where, I mean, the amount of transmission taking place outdoors is really very, very small. So a mask on the streets, I don't think does anything good. And there's been a lot of discussion about masks or yes or no in Sweden, and many are advocating that we maybe should use them in certain situations like public transportation, but there's still no sort of instruction or regulation for that. So most people in Sweden do not use masks anywhere. And I think that I've tried to look at the literature and the number of studies really separating out masks for simple masks for common people. I mean, it's difficult to separate out from other parts of social distancing. But I also I partly disagree with the Public Health Agency in Sweden, and because they, to some extent, claim that that there's no evidence, but then again, we should always remember that lack of evidence is not sort of evidence for the opposite. So I think in certain situations, probably masks can add a little, but mostly in indoor settings. But we don't have any regulations, and I've only occasionally used masks through the last half year.
And you have remained uninfected.
I remained uninfected, which I'm sort of, I'm not happy about that. I would have liked to go through this. Already in February or January, I told both myself and my family and so on that this is something that we will go through. But unfortunately, I haven't had it yet. Of course, I'm at an age where I have a certain risk of having severe disease, but hopefully when I get it, I won't. And maybe there will be a vaccine in time, but I don't think that vaccine will solve this for us.
Sweta, are there any questions from the audience that you would like to narrate for any of our speakers?
While they get started, I can just comment on sort of the protection of vulnerable. Of course, we that's part of the Swedish strategy, and any strategy that is a strategy, I would say. And it's been quite successful when it comes to many elderly in Sweden. We are sort of a rich country. Many elderly live on their own and have contact, but not daily. They don't live together with the rest of their family. So if you look again at the seroprevalence figures I showed, the elderly have much lower seroprevalence, so they have protected themselves. But we have had problems in care homes because the staff there, sometimes probably more staff than visitors, have brought the virus in. So we, like half of the number of deaths that we've had have been in care homes for elderly. But these are very frail patients or persons living there. The life expectancy in these elder care is a special care homes for the frail elderly. And the life expectancy is like a year or so. So it's in terms of number of lost years, it's not dramatic, but still, of course, terrible that the virus has entered into these care homes and caused deaths. It would be good if that could have been avoided, but it's complicated and it still will be. So we are starting to see some cases again among care homes for elderly, but it's still at a very low level.
Partha, could I ask Dr. Gupta a quick question?
Yeah, go ahead.
So in the mathematical formulations that you showed, for herd immunity, do you take into account social density and multi-generational homes? I mean, are they context-specific herd immunity calculations?
So the thing about mathematical models is that I think they provide a very good conceptual framework. So in other words, what Dr. Muliyil was talking about, why do epidemics occur every 3 years with measles? You can take that simple model and you put, the waning of herd immunity and the appropriate, actually some seasonal forcing, and you can get those 3-year cycles. So they're very good for that sort of thing. But what I think mathematical models are not very good for are forecasting, or indeed having, what they can do is they can provide the context which allows you to then say, well, what happens in a multi-generational household? As such, in those very simple models, you have everyone mixing with everyone. So it would, as such, it doesn't inherently have a separation of the vulnerable from the simplest model. And then I showed you another one where you do have the vulnerable in a separate category. And what we've done is looked at what you vary a parameter that tells you how much contact there is between the vulnerable and the non-vulnerable population. So you can set the model up to look at those effects. But the point is that once herd immunity accumulates generally in the population, the risk to everybody goes down. Now, obviously that depends exactly how that happens depends on the specifics of the system that you're looking at. But that is a fundamental feature that can be exploited. Making overly complicated models to say, okay, let's do this, let's have that, let's have a full map of exactly how many households there are, is not helpful in this context. But maybe just the general question of, does this concept apply to a situation where the vulnerable are living in close contact with those who are non-vulnerable? Absolutely, yes.
So maybe I can comment quickly. I very much agree that the possibility to forecast the future sort of spread of COVID-19 and what levels are needed for herd immunity and stuff like that is really difficult, because many of the basic parameters are still unknown, I would say. So they are good at looking at different scenarios, comparing different things, but to do actual forecasting on how many will have a need for ICU in the next 6 months or so is extremely difficult. You should be cautious about sort of trying to rely too much on the forecasting.
So we have a few questions. So I'm just going to combine a few questions and ask all the speakers and the panelists. So there seems to be infection rates that are very different across populations, across different countries. So what do you think is driving that? And what are the reinfection rates across the globe? Are they similar? Are they different?
Was a little difficult to hear, but I heard differences between countries, and of course, like Professor Gupta said, that small countries that are isolated, like Iceland or New Zealand, they can keep the virus out for a while, maybe until there is a vaccine. And then, so there are many differences between countries in terms of population density and how much the different generations interact. I think the main sort of thing when it comes to the global situation is what we heard discussed here previously, that many countries have health systems which are much too vulnerable to focus only on COVID and lockdowns and so on. It will cause so much problems in terms of collateral damage, and that's a big problem with this, I would say, for countries like India and many other countries, for instance, in Africa.
Do the other speakers have any comments?
I think from country to country variation, why some countries have high incidence, others are low, is in terms of what you use to measure the incidence, measuring technique used in different countries. And number two is the amount of actual contact people have with one another in terms of protection use, mask use, or whatever it is. And I think that varies. And when you keep a distance from one another successfully, you can bring down the rate of transmission. So it's fairly straightforward, the factors that are associated with varying rates.
So I could just add to that. I think the age structure, as I mentioned, of countries makes a huge difference to the death rates. But as many people have already done an analysis of, does that account for the stark differences? And it's not sufficient. So I think there must be differences in the pre-existing levels of immunity in these populations. Exactly why? I mean, as I think we're all saying, that there's a lot that's unknown about this virus. So we don't really know what levels of pre-existing immunity there are. They are likely to vary from region to region. These are all things we don't have numbers for, but we do have a conceptual handle on. And that's, I think, where all three of us are coming from. And it's just been really refreshing to have that discussion. So thank you all for that.
And another thing that is likely to contribute are sort of genetic predisposition and risk factors. It's becoming more and more clear that there are certain genetic traits that we carry from birth that influence the risk, together with more behavioral things like obesity and stuff like that. And that differs between different regions. We've seen in Sweden much more severe cases among certain immigrant groups, and whether that's only because of different in social structure, more sort of close living and across generations, or if there are also genetic factors, is still unknown. But genetic factors definitely influence, and we don't know enough about that either yet.
Thank you. So we'll take another question. So New York, Stockholm, and Mumbai have large populations, but the population densities are very different. Does the population size and density have influence on herd immunity?
Well, I don't, to some extent maybe, but maybe more on sort of the rate of spread and the force of spread, I would say, and then also how whether it's possible to protect the frail or not. But maybe the others want to comment as well.
Well, just generally, all those factors contribute to the R0, the basic transmissibility of the pathogen, which actually also is something we don't really know. There's this sort of way that people talk about it as if it's certain that it's around 2.5, but we actually don't know. I think it's reasonable to assume that, but it's just one other of those things we don't know and is likely to vary from place to place. And that determines how quickly it spreads and also the level of immunity required in the population to stop it spreading. But overall, you know, the patterns that we've seen tend to suggest that it is probably of that order, somewhere between 1.5 and 2.5. And, you know, that does depend on what the density is and what kind of contact networks there are. And then it will also determine, it could explain why in some regions a lower seropositivity, whatever that might mean, so it seems to correlate with that herd protection already being achieved, whereas in other places, you don't get that. The other thing it determines, which is quite important, is the overshoot. Typically, in the first epidemic, the numbers infected will overshoot the threshold. So, you know, seeing 60% seropositivity in Dharavi does not mean that you need 60% seropositivity for protection. It usually overshoots and then it drops down, which is what creates those, you know, the sort of epidemic behavior in measles, for example, that Dr. Muliyil was describing.
I agree on that, and that's also sort of one of the reasons why flattening the curve is a good sort of strategy, and also I'm not a fan of sort of the concept of that having no cases is sort of the best strategy. I think having low numbers so that you don't run into problems with providing healthcare for those two.
At the end of the day, it's just a fundamental basic recognition that lockdowns and other repressive measures are, you know, really killing people in lots of the world, in many parts of the world. Until that is lodged firmly in the heads of the people who, you know, just mete out lockdowns, things, it's just never going to change. Who knows what the right optimum is? We need to have a sensible discussion to determine that. But it's just not there in people's heads. And that nobody is thinking internationally. It's sort of, oh, really? Oh, are people actually dying in other parts of the world because of lockdown? I mean, it's a real problem here, I find.
Just a comment on sort of herd immunity and where Sweden might be in the spring or in early summer. I was sort of more optimistic than I am now, that because we saw this massive drop in cases and almost no cases, and especially no deaths and ICU cases in the summer. So I was a bit over optimistic about that we may be sort of close to some type of herd immunity already. But now with the large increase that we see, at least in diagnosed cases, I'm not so convinced anymore. But still, I think we are sort of somewhere on the route towards immunity starting to play a role. But we can't really rely on just saying that, oh, we almost have herd immunity and do nothing. That's definitely out of the question, because we don't know. So we need to keep social distancing up, but I would say without strict lockdown, so that the spread is the rate of spread is significantly reduced until we know better. Otherwise, we risk having too many cases to cope with, and which would be terrible, of course.
I think it's quite, I mean, yeah, it's about finding an optimum in these circumstances. And I think that the fact that it was so low, kept so low of the summer months in many parts of Europe, really, and then started to go up, suggests that, yeah, you were sort of approaching herd immunity in some places, and then those who went into lockdown too early haven't quite got there. But, you know, one can make inferences, but overall one has to be prepared that when winter transmission increases in winter months, that there will be a resurgence. And but I don't think the predictions of the resurgence then kind of becoming bigger than the original wave is one that
I hope the same, but I think that again we can't rely on the fact that this second wave will be smaller, and then do nothing basically. I think we still need to keep prevention up, but at a reasonable level. And I hope and I think that the many parts of the Swedish strategy will in the end turn out to be sort of a reasonable balance between keeping case counts down but still having people being able to live reasonably normal lives. And it works. It may the strategy has to be adopted. I mean, what works in Sweden may not work in other countries. That's also very clear.
Partha, could we take one last question? Is that okay with you?
That's okay, but I was going to ask Sunetra a question. She talked about optimum, and in order to be able to find the optimum, you need multiple strategies. And here we have completely opposite poles, the Great Barrington versus the Jon Snow. How do you actually find the optimum?
Well, the optimum isn't fortunately, between those ideas. The optimum is one which includes the costs of lockdown or costs of any other measure that is taken. So what we need is to optimize in this complex landscape of the harms done on every single axis, not just COVID. So the Jon Snow memorandum, or pretty much the consensus in this country, including what the government advisors are telling them, is that what needs to be done is that we have to keep cases down at all costs. And I think that the voice of reason that we're hearing with the other two, with all of you, is just that that's not even an option in many parts of the world. And even in this country, we have to balance the collateral damage has to be there. And then you optimize. Your objective function is the harm done across the board to the population. And then you optimize on that. So I don't quite understand why you wouldn't do that. Now, how you do that is a matter for discussion. But I think that's, it seems to me that that what's happening now is a kind of, it shows a sort of blindness to the costs of these measures, not just in this country, but internationally. And that's the starting point really for us.
Sudhir, go ahead, ask your question.
No, Shweta has a...
Shweta has a question. Yeah, Shweta, go ahead.
I wanted to know how vaccination will affect herd immunity, and do you foresee herd immunity coming up anytime soon?
Do you want me to answer that? So unlike measles or other childhood infections where natural immunity is lifelong, and you can make vaccines relatively easily, that give you lifelong immunity. So these are sort of part of what I call the low-hanging fruit on the vaccine tree, because natural immunity is so good, you just need to mimic that as best you can. And these vaccines, which obviously one has to rush out to children because they die of things like measles, those are justifiably used and usable in children, and they do build up herd immunity, which is almost, can be entirely vaccine dependent and will be in the future. And that's fine. That's building up a wall of vaccine-induced herd immunity. And that's what can get rid of or keep them at very low levels. Very rarely have we eliminated anything. Maybe we'll get to do that with polio. And smallpox, of course, is in a category of its own. With these sorts of infections, the coronavirus type infection, where you get reinfected and you top up your immunity, reinfection doesn't come, it seems, at least with regard to the other coronavirus, doesn't come with the same burden of disease. I think the role of vaccines will be in protecting the vulnerable, particularly in settings where they cannot be isolated. So we really, really need a vaccine, and we need it mainly for situations and countries where you cannot isolate the vulnerable. So I think the vaccines will play a very, very important role there in focused protection. I don't see these vaccines as playing an immediate role in the buildup of natural immunity or of herd immunity because, well, first of all, happens without cost to children. So to get a vaccine to that level of safety where it would make sense to give it to children, to me is an unnecessary waste of time in licensing a vaccine that could protect the vulnerable. So I think a combination of protecting the vulnerable through vaccination and allowing natural immunity to build up in the population will be what takes us to the best possible solution.
JP, do you have one final message for us?
Yes, even though we were helpless in the face of the coronavirus, because of our circumstances, even though we claimed we are trying to contain the disease, we couldn't. The infection spread. And to our surprise, we actually have fairly healthy levels of antibodies. So what Dr. Gupta said is correct. When the vaccine does come around, we may be able to help top up the existing level of herd level of immunity, whatever that is, especially taking care of the elderly and the other vulnerable. So I think at the long run, even though our containment measures failed, and luckily our mortality is low, okay, unexpected. So India is in a sort of very promising state now with the vaccine coming on.
Professor Alberts, one final message from you.
I also think that we cannot in any country rely on a vaccine coming very soon and sort of solving everything. And I agree that vaccines, when they become available, will primarily be something for the vulnerable, and maybe healthcare workers of different types, but much less of this solution for the general population, I expect, but we will see. Another unknown.
Thank you very much. Let me thank all of you, Professor Gupta, Professor Muliyil, and Professor Alberts for this wonderful discussion. I hand over the microphone to Professor Sudhir Krishna.
Nothing more, Partha, than thank you very much for a very rich discussion. And when we reach out to you again, please give us your time. Thank you again. Goodbye.
Thank you very much. Bye.
Very much.
Bye-bye. Thank you.
Thank you.
Bye.